Welcome to CFRI's Cystic Fibrosis Community Voices, a video podcast series created by and for the cystic fibrosis community.
Everyone knows who you are. Where your fame.
Good evening. I'm here today to talk about the advances in technology and diabetes technology and how the technology can be used in therapy in individuals with cystic fibrosis related diabetes. I am Dr. Marina Basina. I'm an associate professor at Stanford Division of Endocrinology, Department of Medicine, and this is one of my favorite topics. So I will be glad to share that information with you. So first we're going to talk about, in general, just epidemiology of cystic fibrosis related diabetes. So cystic fibrosis related diabetes is the most common complication of cystic fibrosis. It affects about 20% of adolescent and 40 to 50% of adults individuals with CF. Delta F508 mutation has the highest risk of development of diabetes. So other risk factors for development of cystic fibrosis related diabetes are being a female, having hepatobiliary disease, and use of steroids. So there are some differences and some similarities between different types of diabetes. And throughout my talk, I will be referring to CFRD as cystic fibrosis related diabetes, also to type 1 diabetes, and showing some differences and some similarities between those two conditions, and also type 2 diabetes. So diabetes in cystic fibrosis is the most prevalent in cystic fibrosis patient population. So again, its effects on the average about 35% of the individuals with CF. Comparing to type 1 diabetes is very low prevalence. It's about 0.2%, but the denominator is different. So we're talking about the whole population. And type 2 diabetes, unfortunately, we are going into more of the epidemic proportions, and now it's 11% or higher and expected to be even higher by 2050. So the age of onset is about 20 to 24 years old, the peak of onset in CFRD. Childhood, usually adolescent, although we are able to detect now with the new technology, with the our ability to measure antibodies in the blood, we're more able to detect the type 1 diabetes in adulthood and even in elderly population. The patients that were previously diagnosed as type 2 diabetes, it's traditionally was a diagnosis of mid and late adulthood, but currently we're seeing that as patients with or individuals at a younger age getting diagnosed with diabetes. In terms of the body weight for cystic fibrosis diabetes, individuals usually are normal or underweight. For type 1 diabetes, usually normal, although we are seeing more of the obesity in type 1 individuals, and type 2 diabetes, again, traditionally more in the obese patients. In terms of the insulin production, in CFRD, there some insulin deficiency, variable degree, but not complete insulin deficiency. There's still some production of the insulin. In type 1 diabetes, with the autoimmune destruction of the beta cell, there's more of the complete destruction of the beta cells. And with type 2 diabetes, it's a combination of insulin resistance and insulin deficiency. And again, insulin resistant fluctuates in cystic fibrosis diabetes depending on the current state of infection or taking steroids. It's modest in type 1 diabetes and more severe in type 2 diabetes. Hemoglobin A1C is a test that we usually use for diagnosis and monitoring of the treatment of diabetes. We are not able to use in cystic fibrosis related diabetes because this test is not accurate for various reasons. But we do use this test in type 1 and type 2 diabetes to diagnose and monitor the treatment. For the complications, we are seeing more and more of the microvascular complications in CF-related diabetes, which is eye disease, retinopathy, and neuropathy. And patients live longer and healthier life with all the treatments available for cystic fibrosis, but longer the duration of diabetes, the more often we're seeing the complications. And we are seeing both of those, both macro and macrovascular heart disease complications in type 1 and type 2 diabetes. The cause of death of mortality usually is lung disease in CFRD, and it's more cardiovascular disease in both type 1 and type 2 diabetes. So as I mentioned previously, that hemoglobin A1C is not a test that used for the diagnosis of cystic fibrosis-related diabetes. Therefore, Cystic Fibrosis Foundation and American Diabetes Association recognize that and recommending annual 75-gram sugar 2-hour oral glucose tolerance test for the diagnosis of diabetes. And this test should be performed annually over the age of 10 years old. But unfortunately, because this test is not easy to do, you have to be fasting and you have to drink the sugar drink, which is not super pleasant and tasty, and then test blood sugar in 2 hours. So it's a time-consuming. Patient need to be nothing by mouth from the morning or fasting from the night before. Therefore, the screening that actually performed in this population is not where we want it to be. So only 54% of patients are tested between ages 10 and 17, and only 28% of adult population over 18 years old tested for cystic fibrosis-related diabetes. But we do know from multiple studies that the tight control or the good control of diabetes in cystic fibrosis is extremely important. So again, I'll be sort of going through the analogy between type 1 diabetes and cystic fibrosis diabetes, because more data we have, obviously, type 1 and type 2 diabetes than CF. So in terms of the tight control in type 1 diabetes, the largest and the landmark study in type 1 diabetes population that included over 1,400 patients started in 1983. Patients were followed for 6.5 years with intensive glycemic control, including 3 to 4 injections per day or use of the insulin pump, showed that over this period of time, tight control led to reduction in eye disease by 65%, kidney disease by 54%, and nerve damage or neuropathy by 60%. This initial study was not powered to look at the cardiovascular disease outcomes because patients were young and there were not enough of the events in this study. But the study actually is still being analyzed 35 years after its initial recruitment, and we are seeing still the benefits even till now, 35 years later, of the tight control in terms of the cardiovascular disease. So risk of cardiovascular disease events reduced by 40% approximately, and non-fatal myocardial infarction, stroke, and death from any cardiovascular disease reduced still by about 57%. What about in patients with CF-related diabetes? We do know that pulmonary function begins to decline several years before the diagnosis of cystic fibrosis-related diabetes. So it actually starts in the pre-diabetes period. And rate of decline directly related to the severity of the insulin deficiency. Insulin insufficiency or insulin deficiency compromises the nutritional status by creating this catabolic state or breakdown of the protein and fat. The study that was conducted in 2009 in cystic fibrosis-related diabetes therapy study group, which was a multi-center randomized placebo-controlled trial, showed that insulin therapy can reverse chronic weight loss in adults with cystic fibrosis-related diabetes. So what are the metabolic effects of high blood sugar in CFRD? So it had been shown that blood sugars over 144 milligram per deciliter, which is not significantly elevated but above normal, cause the elevated airway glucose concentration and promotes the growth of the infection of the pathogen in the airways. Hyperglycemia increases the oxidative stress in cystic fibrosis. And again, I'm not going to go into detail of all those studies, but the conclusion from many of those studies show that hyperglycemia causes the pro-inflammatory or pro-bacteria growing environment in the airways. So when we look at the cystic fibrosis, we kind of have the two types of the cystic fibrosis related diabetes. One is cystic fibrosis related diabetes with fasting hyperglycemia, meaning when fasting blood sugars are elevated, or without fasting hyperglycemia. And that's what on the slide, what FH negative or FH positive means. And the hyperglycemia promoted the this inflammatory state in the airways in both of those types of CF-related diabetes, with fasting or without fasting hyperglycemia. What about the low blood sugar? When we are treating any diabetes, we're usually worried about the low blood sugar caused by the treatments that we're giving to the patients. So is there any harm of CF-related diabetes hypoglycemia? So it's actually, it had been shown that there are effects of hypoglycemia in cystic fibrosis population. So the study was done on the inpatient population admitted for mostly CF exacerbation or lung exacerbation, but in the individuals had CF-related diabetes. So it showed, they looked at survival analysis to death or over 3.5 years of the follow-up period. And as you can see on this graph, that red line shows the survival of the patient who had low blood sugars on admission, and the black line showing with no hypoglycemia on admission. So you can see the lower survival rate for someone who had low blood sugar. There could be a lot of confounding factors, including poor nutritional state, causing more of the increased frequency of the low blood sugars. So it's probably multifactorial, probably not just hypoglycemia itself, but again, it's sort of a marker of a poor outcome. On the other hand, while in the hospital, high blood sugars and actually glucose variability did not show significant effect on readmission and mortality, although the study was not designed or powered to determine this effect of the high blood sugar or variability. So now we're going to switch to a history and evolution of glucose measurement devices, which goes back to several centuries ago, and I'm not going to go to that far because otherwise it's fascinating history, so we can talk about this for hours. But the actual blood sugar meters were introduced only in 1980s. So before that, patients were using the urine test strips. And the first urine test strip was a pretty big size, and it was made from the sheep wool. And when people will pee on that test strip, if there is enough sugar in the urine, it will turn black. So that was the only test to measure. Obviously, you can imagine that it was not super precise measurement. Then in 1980s, the first blood glucose meters were introduced. So I don't have the picture here of the first one, but the first one was about close to 50 pounds, and it needed to be plugged to the wall in order to use it. So obviously it wasn't the most convenient way of checking the blood sugars. And the glucose, the lancet device, or the poking the finger device, was this huge lancet device that required a 50 to 100 microliters blood sample, which was huge. Patients who still remember this device, they call it guillotine because it was super painful to get the blood. And now we are down to 0.3, 0.6 microliters for the blood sample, and you can see one of the meters, but we have many meters with tiny lancet devices. Now we're in the era where we're even trying to make life more easier and to go away from the finger sticks. and trying to introduce CGM technology, which stands for Continuous Glucose Monitoring Technology, which is a fascinating field. If you can see that sensor, this is a kind of the cross-section of the sensor that's shown right here. So you can see that tiny hair thin little sensor that stays underneath the skin, inserted in the subcutaneously. So it measures the glucose not in the blood, but in the interstitial fluid, so in fluid that circulates between the cells. So blood glucose diffuses from the blood by a gradient to the interstitial fluid, and you can look at the cross-section of this sensor. So there's a membrane that allows only glucose to enter the next layer, which is the enzyme-covered layer, and it prevents other saccharides to get through it. And sugar then reacts with this with the enzyme, which is glucose oxidase, and it converts it to hydrogen peroxide with the generation of the protons that get detected by the electrode and send the data to the little transmitter that gets this information. And then transmitter sends it to receiver that analyzes it and tells us what the blood sugar actually is. So obviously there are some delays. So there's a delay for blood sugar to diffuse from blood to the interstitial fluid, for this whole chemical and sort of electrical reaction to occur, and then for the device to actually analyze what that is. So this delay is about 10 to 15 minutes on average. So the first commercially available continuous glucose monitoring device was designed by Medtronic, and it was available since 1999, and I actually had a pleasure of using it. It was pretty good sized device. The actual sensor, it was pretty long. It was 17 millimeters, pretty painful to put it on. You cannot disconnect from this device, so you wear it 3 days in a row constantly, 24/7, in order to get the data. The data was blinded. It was not a real-time glucose monitor. Since you can disconnect it and you somehow need to take a shower, there were special shower bags that you put around your neck, and then you put device into this bag, and then you, again, if you need the next day take a shower, you do the same thing. So then we have the more modern sensors that are shown over here in the structure of that sensor that I showed you before. Which are way smaller, way easier to put in, and last for 7 to 10 days. They do need to be some sensors need to be calibrated with the finger stick. So by calibration of doing the finger stick twice a day and entering that into the CGM, into the receiver device, it teaches the sensor what this electrical signal means. Again, current new technology allows patients not to calibrate, so it's actually factory calibrated. So they run in the factory with various blood sugar levels, and it's all calibrated in the factory, and already patients do not need to even test their blood sugars. So some of those devices that are currently available, Dexcom, which is has several generations of sensors. The previous generation that is still available, we still use it, is G4 Platinum. Currently we use more of G5, and I'll show you the new G6 just came out. So for G4 and G5, there are 2 calibrations required. Those sensors have an ability to follow and to share with other devices. So patients are able to see the data on their phones and on any of the smartwatches. It doesn't have to be expensive Apple Watch. It can be any cheaper watch like Pebble Watch. I think you can get the cheapest one for like $59, and you can share it with your family members. Up to 5 family members or friends can follow and see what your real data is. They are Bluetooth enabled, and the followers can have also either smartwatch or Apple phone or certain types of Android phones, not all the Android versions. Medicare now covers the Dexcom as a non-adjunct use, meaning that it does replace the finger stick. So you can base your insulin dose decision, treatment decision, based on what the reading is on CGM. You don't have to use the finger stick for they decide how much insulin to take. So the G6, the newer version of Dexcom, was approved in just this year in March 2018. That one is factory calibrated, does not need to be, finger sticks are not required. It has a receiver, so you can see blood sugars on the receiver. If it's pointing, this little thing pointing to the horizontal, that means that the blood sugars are stable. So it's not only showing you what the current blood sugar is, but it's also showing you where are the blood sugars trending. Are they going up or down? Which is very important. So I always tell patients that you can use it as your GPS to see where you're now and where are you going. So it's inserted fairly easily with this device with the inserter, which is just this orange button, one button push. And it's a 10-day wear. And again, you can share it with 5 either family members or followers. So all the devices, meters and continuous glucose monitoring device, for their accuracy, we estimate using the term MARD, which stands for mean absolute relative difference. So the lower the number, the more accurate the device is. What this number is, it's a % difference between what the device showed compared to the reference device, whether that's a glucometer or the blood test or it's a glucose analyzer in the laboratory. So unfortunately, none of the devices are super accurate, but if we're talking about the glucometers, the FDA approval MARD for the blood sugar meters is plus minus 20%. We're trying to get it lowered down to 15%, but again, some of the meters still cannot meet this target. So if you can see some of the CGMs, the MARD is 9%. So some of them possibly could be even more accurate than some of the glucometers. This is another device that's approved in the US and Europe, was initially approved in Europe a few years ago, approved in the US last year as a 10-day use, and approved this year as a 14-day use. The 10-day use we have been using for the past year, but the 14-day use is not available in the pharmacies yet. So they're saying in the next 2 to 3 months we should be able to exchange and get those devices in the pharmacy. So you can see this little flat sensor that is inserted. It literally takes 1 minute to put it in. It's absolutely painless. It stays for 10 days, and in order to check your blood sugar, you just scan with the reader, and again, you can see what your number is, and you can see a little arrow which showing you whether your blood sugar is going up or down. It's a touch screen, and again, it's a real time, and it captures and stores the reading 24/7 for those 10 days. It has a 12-hour warm-up time. So for the first 12 hours, you cannot see your values, but after 12 hours, you can see for 10 days. And you can see how neat and how interesting this little thing is inside to be able to check the sugars. So the new, another new exciting technology, it's called Guardian Connect. So it's approved by Medtronic in March of 2018, this year. So this is the little sensor over here with the transmitter. It transmits the data to your iPhone. Android is not available yet, should be available by the end of this year. So it needs to be calibrated twice a day, and it has it's approved for 7-day wear. It has this application on the phone that's called Sugar IQ. So it kind of analyzes the blood sugar patterns and gives you some advices on what to pay attention to if you have a pattern of higher blood sugars after lunch or low blood sugars during certain times of the day, and advises you to either talk to your doctor about it or to consider some changes. It doesn't give you exactly any of the the dose suggestions, obviously, because it's not approved for that, but sort of gives you the pattern recognition. So that some patients like it, but it hasn't been used that much. Again, it's just recently hit the market. So this is the newest device that just got approved in June of 2018. It's an implantable sensor, so it's a tiny little sensor that's shown right over here. It does require 2 calibrations per day. It's inserted into the arm, and it's a little sort of semi-surgical insertion. It is a little cut, about 0.5 centimeter cut of the skin, and then it doesn't need to be sutured, so it's just a little stir strip that we put on the skin. It heals pretty well, so it stays inside the arm for 90 days as of now here in the US. It's in Europe approved for 180 days, and we probably will be able to get it approved for 180 days by the end of this year. So there's some benefits and some disadvantages of this, some pros and cons for this device. So one, the benefit is that you have this reader, so you still have this transmitter or reader that is attached to the skin. The sensor only works when you wear the reader, and the reader sends the signal and activates the sensor. The benefit of it is that for someone who has low blood sugars in the middle of the night and not able to hear the alarm and alert from other devices, this reader actually vibrates on the skin, so it wakes you up, and you can set up a different strength of the vibration, so it wakes you up while you're asleep because it vibrates on the body. So that's one benefit. The other benefit, that you don't have to think about insertion every 7 to 10 days. It's there for 3 months, but again, every 3 months you have to go to the doctor and have it remove the old one and reinsert the new one. So hasn't been used that much yet, and I think if we get it approved for 6 months or for 180 days, I think it will be used a lot more because it will be providing more benefit. It is a little bit more accurate than other sensors, so reported MARD, or the accuracy, is 8.5%. So this is just, again, marked for all those available sensors. And again, as I mentioned, the lower the number, the better. So we're talking about the Dexcom G5, and G6 is about 9%. Dexcom G4 is going away. Abbott, the Freestyle Libre, is about 11.4%, and it's a little bit less accurate, more like 20% or even higher in the hypoglycemia range. And again, the lower number, the better. So now we're moving to the insulin delivery devices, and then we will discuss how to integrate measuring devices and insulin devices in one system. So the first insulin pump was developed or introduced in 1963, and this Purcell Arnold Kadish, everyone uses his picture in his presentation. If he would have charged 1 cent, he probably would have been a billionaire. So this pump was like a backpack, and it was delivering insulin intravenously. But it actually worked really well because intravenous insulin worked really fast, so blood sugars had been under excellent control. But since that, we had made a lot of advancement in the technology. Later on, this biostator got introduced. It was more for, in 1976, it was more for the hospital use, and I think we still have it at Stanford. It did work well. We did some studies. I didn't do it at that time. I wasn't there, but there's still physicians, especially in pediatric, our technology gurus, who had been using this device in biostator. Again, an intravenous infusion of insulin, and it worked pretty well. Then it was this auto syringe. That syringe was outside the pump because syringe was so large and it was not able to deliver tiny amounts, so the insulin had to be diluted. So if the usual insulin concentration is 100 units per 1 ml, this syringe would take 40 units in 1 ml. So it had to be diluted because it couldn't deliver a small amount, right? So in order not to get low blood sugar, the insulin had to be diluted for that. So what are the principles of the insulin pump delivery? So it delivers, this is a little plastic catheter that's inserted underneath the skin, insulin flowing through the tubing, through the little device pump, which I will show you. So the insulin get delivered into the fat tissue or subcutaneous tissue. So it delivers basal insulin 24/7. So we're all producing some basal insulin. Even if we're fasting and for 24 hours, our pancreas is still producing small amount of insulin. And that's what it does. It sort of trickles this tiny amount of insulin every few minutes. And then when we eat, we spike and produce extra insulin to cover the meals. So this is what the pump does, but it can't do it automatically, unfortunately, yet. So we're trying to to make those devices, but we're not there yet. So we're manually entering how many carbohydrates individual is eating, and the pump does the calculation of how much insulin to deliver to cover the meals. So the pump has this bolus calculator, and the setting for the bolus calculator include how many carbs are in the meal, what is the correction factor, how many units need to be delivered extra to cover high blood sugar, or subtracting if the blood sugar is low, what the target blood sugar is, what it needs to be targeted to, and it has the insulin action time, which is an extremely useful measure because if you, especially in cystic fibrosis population, because of frequent snacks are needed. So if you had given yourself insulin 2 hours ago, you still have about half of that insulin in the body. So the pump will remind you that half of insulin is still there, and it would subtract it for you. So you don't have to think about it, and you don't have to do the math. So those are the current devices that are available. So this is Medtronic pump, the older version. This is how it works. So the insulin is in this little cartridge or syringe. It flows through the plastic tubing into the body. Again, this is the infusion set, and it has the small plastic catheter that I showed you before that infuses the insulin into the subcutaneous tissue. If you take a shower or if you need some sort of activities that you do not want the pump to be on the body, you can disconnect it from this place, this area, and then reconnect it when you need it back. So this is the most current Medtronic pump. It actually linked with the meter. So if you do check your blood sugar, it automatically beams into the pump. This is the sensor, Medtronic sensor that I showed you before. It's also wirelessly transmits all the data into the pump and shows you on the screen. This is a new Tandem or T-Slim pump. This company is located in San Diego. It's a very small, fairly flat pump that is all touch screen, does not require any batteries. It's USB charged with any USB port, and you can see Miss Idaho is happy with the pump, wearing this pump. The other pump is the Omnipod. This is the pod. It's a patch pump. So the insulin is inside this pod. It's not connected with any tubing to the PDM, or it's called the diabetes manager device that is wirelessly sends the signal. If you want to eat and take a bolus, you enter the blood sugar into the PDM, or you can put the little test strips here and measure. It goes straight into the calculator. It calculates the blood sugar. You just push the button and the insulin gets delivered. You cannot, this stays on the body for 3 days, and you cannot disconnect it, or if you can disconnect it, but if you disconnect it, you have to put a new one. So you cannot reconnect the same one. And you can see little kids, they love the freedom, they love that they are not connected to any tubing, and they are wearing this device. And you can have any of the cool tapes or any print you want. You can order any of those on the internet with any pictures you want. To fill this pod, I don't have a picture of the back side of the pod, but there is a little hole on the back side underneath that you put. It comes with a syringe and a needle. You get the amount of insulin you need from the vial, and you put in this little hole in the pod. So the minimal amount that you needed for the pod to be activated is 80 units. So once it hits the 80 units, it gives you 2 little beeps. That means that minimal amount is reached and you can use the pod. But if you need more, again, it holds up to 200 units for 3 days. So it depends on how many units you need for 3 days. Yeah, it's very easy. It walks you through it. So when you push the PDM home button and you tell the pump that you need to change your pod, it gives you all the steps. So it walks you through it. It's really easy. Even if you've never done it before, it's pretty self-explanatory how to do it. And kids usually do them themselves.